And this is where I'm so generous. We did a whole body CT and did not reveal any other abnormality. So I'm already giving you very useful piece of information without you asking me. So in this case, I'll also show you the imaging is sizable mass, which is very heterogeneous. And there's no vascularity in the nodule, but on color Doppler, increased vascularity surrounding the nodule, which is not a very specific finding. So this is the FNA morphology. You can look at the amount of cells, the type of cells, the architecture of the cells, presence or absence of colloid, lymphocytes, amyloid, or other things. So is that enough, or would you like to see more? So now you can see the cells are in fragments. You can see the nucleus size and shape, presence or absence of nucleoli, presence or absence of lymphocytes in the background, whether the cells are microfollicular or gland forming, as seen here. And even at this magnification, you can see huge nucleoli in most of the nuclei and sprinkling of lymphocytes in the background. So I think we have enough for the diagnosis. More? Okay. So Pap stain shows you vascularity. So you can see the hyperchromasia in the nuclei. Once again, vesicular chromatin, which is defined as open chromatin pattern, in the background of which you have gigantic nucleoli, right? Beautifully seen here. Some suggestion of necrosis or karyorrhexis. And again, you can see the presence or absence of colloid, amyloid in the background. Enough or more? Enough. Let's see more. So this is the highest magnification I could show you. Again, nesting of the cells. Nesting means they are true tissue fragments forming an architecture. Large nuclei, open chromatin, macronucleoli. In this case, suggestion of gland formation or at least some rosetting of the cells. You can see open chromatin, macronucleoli, some lymphocytes in the background, syncytium because the cell boundaries fuse together, creating this jumbled up mass. Some substance was present, either amyloid, colloid, collagen, or something else. Again, the same cells, some lymphocytes as well. Higher magnification shows you the most impressive macronucleoli in these cells in a background of open chromatin. Again, suggestion of whether there is a gland formation here. Same thing going on here, open chromatin, macronucleoli. This was my case, and I thought that it's an easy case of metastatic adenocarcinoma because there's no colloid. These are gland forming. Look at the macronucleoli. Thyroid lesions typically don't have those features, but maybe I was right, maybe I'm wrong. Most likely I'm wrong. That's why I'm telling you what I thought. So let's apply the Bethesda system. Non-diagnostic. Unanimous decision. It's not non-diagnostic. Benign. Are you sure you remember the first case? AUS, follicular neoplasm. Yes and no, both. Suspicious for malignancy. Malignant. Yeah, how can you not call those cells malignant with huge nucleoli, pleomorphic, suggestion of necrosis, vascularity? In terms of specific diagnosis, is it a poorly differentiated thyroid carcinoma? It does look very worrisome, aggressive. Could this be anaplastic or undifferentiated? Although it looked worrisome enough, but didn't have the pleomorphism that you typically see in anaplastic, metastasis would be way up on the top of list of differential diagnosis, or maybe something other. So when I called up the endocrinologist, I told him I favor a metastatic lung adenocarcinoma. He didn't like the diagnosis. He said, absolutely not. Lungs are clear. Whole body CT did not show any lesions. So he wasn't happy with that differential diagnosis. I ended up calling it something which I'll show you in a minute. But this case involves what is known as stretching your imagination, that you have seen this morphology elsewhere, but you cannot put it in the context of this thyroid lesion. So once you open your mind, stop thinking about thyroid, and think of something else, maybe you will get to the right diagnosis. Melanoma is a beautiful diagnosis. We often forget the great mimicker. I call it mimicker in chief because it can look like anything, including a adenocarcinoma. So would you like to ask me a question on behalf of the entire room? Maybe I didn't give you the full history. What would be the question you will ask me? What is the question? So they're asking, is there a skin lesion or history of melanoma? Here comes the answer, no. So in any case, I got a call from the resident who was grossing the specimen one fine morning. And whenever someone calls you from the grossing room, you're always concerned that he or she will tell you, Dr. Ali, you called something carcinoma. We can't find the tumor. Could you come and show it to us where the tumor is? Well, fortunately, in a horrendous specimen, total thyroidectomy, laryngectomy, sentinel and right neck dissection, the resident did describe a 6.8 centimeter tumor. And there's the gross appearance, left lobe near normal, right lobe replaced by this big nodular mass. Cut section shows the nodularity in the tumor with gray white surface. And indeed, it did involve the vocal cords, leading to laryngectomy with negative tracheal and soft tissue margins. That's the resection. There's the higher magnification of the resection, same cells. And the answer is in this photograph. So what do you see in this photograph? Yeah, you see a beautiful river. This is Schwenstein Castle. So you see the beautiful river. You see these trees in autumn, the foliage. And then you see this castle. So what is the answer? It is the castle. So carcinoma showing thymus-like differentiation. It was very interesting. It extended into the tracheal wall with 2 of the 80 lymph nodes positive. And this is what you see here. The thymic remnants in thyroid can develop into thymoma or all the way to thymic carcinoma. And one of the most common phenotypic appearance of thymic carcinoma is the lymphoepithelioma, like which is shown here. So that's why I said you have seen it elsewhere. The same type of morphology with basophilic cells, large nuclei, macronucleoli, lymphocytes, collagenized stroma separating the tumor into lobules. So typical morphology. Dr. Rozai came up with the term thymus-like differentiation in carcinomas. They arise from either ectopic thymic tissue or remnants of branchial pouches. They are quite rare, but clearly this case illustrates beautiful cytomorphology, and as you can see, matching nicely with what is seen in the histology of these tumors. So open chromatin, round nuclei, macronucleoli. We wrote a series and published many years ago, multi-institutional study, but this lymphoepithelioma-like carcinoma was the most common subtype of Castle in the thyroid. So final diagnosis is Castle in this case. This is an 11-month-old boy, and that's the thyroid FNA. As you can see, very blue. So we thought that either it's a neuroendocrine tumor or a lymphoid lesion because they are stroma poor and give you amazing cellularity. It was even sent for flow thinking it could be a lymphoma, but on resection turned out to be ectopic thymic tissue in this particular thyroid. So that's the benign end of this lesion. So case 3, very quickly, 46-year-old female who has 3.2 centimeters solid left thyroid nodule, which is present for 2 years. And once again, I'm so generous with the history. I'm already telling you the diagnosis is positive for papillary thyroid carcinoma in the mother. So strong family history. So Hassan is looking at me that if I'm just bluffing or giving you the right history, but that's the appearance of the lesion. So you can look at the cellularity, the arrangement of the cells, presence or absence of colloid, amyloid, or something else in the background. That's the higher magnification of something that I showed you in the first slide. And again, you can see that. But again, some of you who have very good vision would begin to see something going on here. And if you have any doubt, and look at the granularity in the cell cytoplasm. If any doubt about the diagnosis and intranuclear inclusion, here you have it. So non-diagnostic, benign, AUS, follicular neoplasm, suspicion for malignant, malignant. They are so confident. They will hate me after this. So medullary thyroid carcinoma is the number one differential here. Beautiful intranuclear inclusion and amyloid. Not our case, but differential diagnosis. PTC, we already showed, saw a lot of cases, paraganglioma or some other lesion. So William Shakespeare said something beautiful. It can be Hashimoto. There were no lymphocytes. But written here is, all that glitters is not gold. The internuclear inclusion was glittering. Remember the Frankie Valli song's lyrics? What did he say? You are too good to be true, can't take my eyes off you. So your eyes were just glued to the intranuclear inclusions. And you just asked me the question about hyalinizing trabecular tumor. This is a hyalinizing trabecular tumor because this is a tumor which have many intranuclear inclusion that you typically would not see in medullary or papillary carcinomas. So we know it's very rare. I'm not going to go into detail, but the latest thing does show the GLIS rearrangement. It's the latest thing it's a very low risk tumor like NIFP. So all of you who said malignant are partially right because it can behave aggressively rarely, but it's typically considered a benign tumor. Which Bethesda category would I use it? That's the question. I think I would call it follicular neoplasm with a note that differential diagnosis includes a hyalinizing trabecular tumor. Unless I'm absolutely confident, I will just call it hyalinizing trabecular tumor without any clarifier. So this is the cytohistocorrelation. That's not amyloid. That's the basement membrane type material, which is typically present in hyalinizing trabecular tumor. And even in histology, you can see beautiful intranuclear inclusions and PTC type nuclei matching up with what we saw on cytology in this case. Major differential is with paragangliomas, which typically arise in the subcapsular location in the thyroid. And even when they invade the trachea, they still carry excellent prognosis. And I'm showing it to you, although it's a rare lesion, that the first time when it was described hyalinizing trabecular tumor and named as such by Dr. Carney at Mayo Clinic, it used to be called paraganglioma, like thyroid carcinoma at that time because of the amazing resemblance to the paragangliomas. And these are some examples of paragangliomas of the thyroid, very similar to our case. And those of you who have seen it in cytology before, they are rich in sustentacular cells, and they also have internuclear inclusions, just like hyalinizing trabecular tumor. There are other examples of HTA from our collection. They can have cytoplasmic tails, beautiful intranuclear inclusions, again, glittering like gold. And that's why they trick you. They can be very spindly. They can have hyaline walls, again, basement membrane type material. They can be very vacuolated, but still containing internuclear inclusions. They can be very spindly. Interesting, even when they're spindly, they still have intranuclear inclusions. So again, too good to be true. Remember that. That's the theme. And again, that's a reference, take-home message. Not all thyroid lesion with incies are malignant, and certainly it's a close mimic, HTT or HTA of MTC and PTC. Whenever you have doubt, you're not confident, just stay on the conservative side. Call it follicular neoplasm and express the differential diagnosis. So next case is another interesting case. Maybe this is time that I show you an easy case and not trick you. It's a 55-year-old man with a 3 centimeter solid right thyroid nodule present for 3 months. Nodule showed coarse calcification, which radiographically were thought to be suspicious of papillary thyroid carcinoma. This was my case, and when with my trainee fellow, I walked into the ultrasound room. I distinctly remember radiologist already was ready with a needle in his hand because we were late. And he told us it's papillary thyroid carcinoma, and we will quickly move on to the next case. But we all know when that's the plan, it never happens that way. It becomes a little bit more difficult case. For some reason, when I did the on-site evaluation, I sent it for flow cytometry. So most honest, right here, maybe I made a mistake, maybe I did not, but I just wanted to give you that information. It's a $800 investigation, so I just wanted to tell you that we shouldn't be casually doing flow cytometry on every case. So that's the FNA. You can look at the cellularity, the amount of cells, the appearance of the cells, the NC ratios, the background, whether cells look lymphoid or otherwise. So this should be enough to make the diagnosis. You agree? Or more? But do you think the flow idea was a good one? I'm so happy you agree with me. So that's more appearance on DiffQuick. Slight adhesion of the cells, but we all know on DiffQuick it can happen, right? Slight rim of basophilic cytoplasm, occasional macronucleoli, for example, right there. Some suggestion of lymphoglandular bodies, but I think the first slide probably had more lymphoglandular type bodies, which are seen as a lymphoid feature. If you like to see mitotic figures, 1 and 2, possibly more, but again, a very basophilic cytoplasm. So if it's a lymphoma, it certainly would be an aggressive lymphoma. So are we done or more? So that's the last one I want to show in DiffQuick. So what do you think is the diagnosis? Lymphoma, absolutely. Out of respect, you're agreeing with me that I send it for flow, so maybe I appreciate that. Maybe I was wrong. So next day when the Pap stains came out, they look a little different. As you can see, the cells are slightly more oat cell, more neuroendocrine, especially with the chromatin, and there was some molding of the cells. So I picked up the phone and I called up the endocrinologist and I said that I did flow cytometry. I haven't gotten the results back yet, but I think it looks different now. It looks like a small cell carcinoma. And I said, I think it's metastatic from the lung. Same nasty endocrinologist said, no way, the patient is a non-smoker. There's nothing in the lung. So it's not a small, but we see small cell all the time where you don't see the lung lesion. It's an occult metastasis. It can happen. But he was not happy with that diagnosis. So let's apply the Bethesda system. Non-diagnostic, benign. This is the third time you could be wrong. AUS, follicular neoplasm. SFM, malignant. Absolutely, with those mitotic figures, how can you think benign? So now what is the diagnosis? Medullary thyroid carcinoma, non-Hodgkin lymphoma, poorly differentiated carcinoma, insular. They can look neuroendocrine also, but they are tight fragments. Metastatic small cell carcinoma, absolutely, is in the differential. So any other question before we go to the final diagnosis? Calcitonin was not elevated. Any other question? Flow cytometry, yes, we spent so much money. What happened to the flow cytometry? So here comes the flow cytometry. Those cells, as you can see, are CD45 negative, so they are not lymphoid. And when you gate them further, they all are expressing CD71 activation markers, so it's clearly an aggressive tumor. And when you gate these further, they are all CD56 positive, which means that it's likely is a neuroendocrine tumor. So indirectly, our money we spent paid off. So we made a mistake in this case, not a diagnostic mistake, but a technical mistake. When we go to the FNA suite imaging, radiology, we don't introduce ourselves to the patient. It's always a good habit to tell them, I'm the pathologist who will be looking at the cells, and I am the one who will tell your clinician what type of tumor, if you have a tumor, that is leading to your treatment, because of course we play the most important role. And in a minute, I'll tell you how proud we should all be being pathologists. which we did not do, because at that time when you have a conversation with the patient, you can get additional history. So I told my fellow, call up the endocrinologist and ask them the history. Radiologists at the time of FNA said there is no history in this case. And sometimes you believe your radiologist, other time you don't, because they're in a rush also. They know everything about the imaging qualities, size, nodularity, vascularity, everything. But sometimes they don't bother about the history or other things, because their intention is to give you sample and move to the next case. So radiologist had already said no history. My trainee called up the endocrinologist, and endocrinologist said no history. So what should be the next step? Ask the patient. Absolutely, what a wonderful idea. We as physicians have every right to call up the patient and have a conversation with the patient, which we missed doing it when we did the on-site evaluation. So the fellow pulled out the patient address and phone number from the electronic record, called up the patient and said, sir, we are looking at your case. Did you have any previous history? I'm going to skip some of these slides. So here is the answer of what patient said. So all you have to do is to identify these two individuals and you know the diagnosis. So I'll give you the names and then you will know. So the gentleman on the left, his name is Sigmund Merkel, the German anatomist who described the Merkel cell. But the tumor was described by Cyril Toker, who was actually at University of Maryland, not too far from us, and then he practiced in New York City at Sinai, originally from East Africa. He described the tumor, did not name it Toker tumor. He was a very nice gentleman. And initially, this was called trabecular carcinoma of the sweat gland, and then we discovered it's a neuroendocrine tumor, and we all know the association with the polyoma virus. So now, when my fellow called up the patient, 1 minute call, oh yes, I had a tumor removed from my elbow, which was a Merkel cell carcinoma. So it could have saved us all the grief, the mistake that we made. So indeed, it was an isolated metastasis of a Merkel cell carcinoma to the thyroid. I'm not going to go into details. Everyone knows how it's diagnosed. And these are some other examples. So I'll move right to the next case. It's a 75-year-old female with bilateral thyroid nodules. And I'm showing you the FNA from the left lobe, which is 7.9 centimeters. So this is liquid-based, thin prep on this case. More? So very clean background. But the cells look a bit pleomorphic. You can see the nucleus size. Some are small, some are intermediate, some are significantly larger, very hyperchromatic. Well, one thing is they are forming syncytium, meaning they are fused together. And these are conventionals, again, showing you size variation, very clean background, macronucleoli, again, adhering to each other. Again, syncytia formations here. Cytoplasm is slightly more opaque, little bit more polygonal look to these cells. And some cells have beautiful intranuclear inclusions, but they all are adhering together, and clearly a lymphocytic population is present in the background. Pleomorphic, but still sticking together. And I'm showing you an intranuclear inclusion here. A little bit opacity to the cell cytoplasm, but peculiar that they are all seen as small syncytial fragments. No amyloid, no colloid. Non-diagnostic. So do you think we can make a diagnosis based on what we have? Okay, benign. Everyone is silent because it's a slightly unusual appearance. AUS. That's the easy way out to call it AUS. Follicular neoplasm. Suspicious for malignancy. Malignant. This was a very interesting case. It was actually sent around to several experts, and most of the people call it suspicious for malignant or malignant. And these are top-notch cytopathologists in the country who looked at this case. So I think the differential diagnosis would be poorly differentiated carcinoma. Maybe it's a well-differentiated carcinoma, some kind of PTC subtype. either a metastatic carcinoma, maybe the theme is from me to trick you in every case, so maybe it's a benign adenomatous nodule. So how many think it's benign? One bold person say it's benign. Very good. So metastatic carcinoma is there, and all you have to do is to ask me a question and I'll give you the answer. That's a big question. History of a malignant tumor in the patient. That's a very good question also, because it will cover everything, right? So it's not melanoma, it's not adenocarcinoma. So the answer is there is no previous history in the patient. So the patient underwent a total thyroidectomy. So obviously it was called malignant or suspicious of malignant. It was an outside case. I didn't render official opinion, but when I looked at it, I also thought it's suspicious of malignancy. So this is the thyroidectomy. So here is the benign thyroid, and this is the lesion. Same groups of cells that we saw in syncytia, but very peculiar that it surrounded the benign thyroid. So do you think it's a metastatic carcinoma? There's such a sharp delineation. But if you look at the higher magnification, they show squamous differentiation. These are squamous cells, and they're filling up these spaces or follicles. And there's a background of Hashimoto thyroiditis, clearly. So any last word? Absolutely. Someone said the diagnosis. So it's adenomatous nodule with extensive squamous metaplasia. It's a leading pitfall, and that is the cytohistocorrelation in this case. So we all know squamous metaplasia is the leading culprit in so many locations, including the thyroid. It can be seen in a number of conditions. We know Hashimoto thyroiditis can have it. In this case, it was adenomatoid with a history, in this particular case, of a very long-standing lymphocytic thyroiditis, but adenomatous nodules can have it also. And there are other conditions. So I love to remember things by showing you lyrics of a song. And there is a famous Australian band growing up when I was in Pakistan in medical school. We used to listen to Simply Red and this song. So remember the lyrics. If you don't know me by now, you will never, never, never know me. And that is squamous metaplasia. We know it's a pitfall in GYN pathology. It's a pitfall in lung cytopathology. It's a pitfall in salivary gland cytopathology. And now we know it's a pitfall in thyroid cytopathology. So know to recognize the features of squamous metaplasia. And once again, there are published series, and this one published from the Harvard group, which showed even more atypical looking squamous cells here. And it will be very hard not to consider a suspicious for malignancy or a malignant diagnosis. So it's an uncommon cause, but it certainly is a potential cause of false positive diagnosis. Intranuclear inclusions would be very rare, but in this case, certainly we saw intranuclear inclusion. So this is another thing you can add up to the list of cases with intranuclear inclusions that can be seen in a thyroid FNA. So we all had fun looking at these cases. I often share these quotations, which are my favorite, that the only people, scientific or other, who never make mistakes are those who do nothing, and all of us work very hard. A life spent in making mistakes is not only more honorable, but more useful than a life spent doing nothing. So if we make mistakes, we shouldn't feel bad, because we learn from each other's mistakes, and happily I shared some of the errors from my practice to you. So next picture shows you how you feel after this unknown slide seminar. You will feel very relaxed. That's just all done. So I was asking Asif about the makeup of the audience sitting here, and Asif said that a lot of people are going to be trainees. So I thought that I'll bring some motivational slides to tell the junior people, either junior faculty or trainees, what a wonderful world of pathology you are in as a trainee. I was trained by Juan Rosai, the great Juan Rosai, at Memorial Sloan Kettering, and He had published many books. One of the book which I personally love to read every time I get time is this book on the history of American surgical pathology, but the title is very important. He said, Guiding the Surgeon's Hand. How important is our contribution as pathologists, both surgical pathologists and cytopathologists, in the care of the patient with thyroid or any other disease, because our diagnosis will lead to surgery, and then frozen sectioning, margin evaluation, nodal status, everything will define the extent of the surgery. So it's very important that we feel proud of what we do and what are the training that we are getting to be a pathologist. And I cannot resist the temptation of showing this famous painting, which was done by John Singer Sargent, who was a British painter, which shows these 4 outstanding individuals in the history of medicine. These are called the 4 doctors, the 4 founding doctors who founded the Johns Hopkins Medical Institution, the Johns Hopkins Hospital. I will tell you who they are. This is our first chairman of pathology. His name is William Welch, who described the Clostridium welchii. He was our first dean of the School of Medicine. And he's also the founding dean of the School of Public Health, which is the most eminent school of public health in the world, the Johns Hopkins Bloomberg School of Health. The individual standing in the middle is called the father of modern surgery, William Halsted, who started the Halsted radical, the radical mastectomy. Before that, patient used to die of the horrendous breast cancer surgery. He's the one who started spinal block, the general anesthesia. He's the one who started to wear gloves when operating on surgery, because before that people used to do with their bare hands, and we still have his Goodyear rubber gloves in the museum that he wore. Unfortunately, he became addicted to morphine when trying general anesthesia and other medications for pain, and did not have a very good ending, but still a wonderful, wonderful guy. And on the right is Howard Kelly, the famous gynecologist who started the discipline of gynecology as we now know. He's the one who first used radioactive or radium for the treatment of cervical cancer. And he's the one who also started absorbable sutures when treating, when doing surgery. So again, a pioneer in his field. And I saved the last one, who is by far the most well-known individual of all time, Sir William Osler, who was the physician-in-chief of Johns Hopkins when it was founded. He's the leading educator to this date. People know him as the best educator of all times, and he's the one who wrote the first textbook of medicine, the practice of medicine, a 800 or 900 page book to this date called the Bible of Medicine. He's also the one who was a philosopher and started many educational things in medicine. But the most important one he did was that he started the concept of residency or house staff. He's the one who coined the term residency, because these residents used to live in the hospital, were not allowed to go too far. They were literally like monks working hard day in and day out in the Johns Hopkins Hospital. He's the one who brought the medical student to the patient bedside. Before that, medical students were only taught in the classrooms and not at the patient bedside. But most importantly, he was a great friend of pathologists, and he said something wonderful, and I'm showing you here. As is our pathology, so is our practice, that the standard of care of patients in any medical institution depend on the standard of pathology. And that's why the trainees sitting here and the audience should feel very proud that they are getting training to be pathologists. What the pathologist thinks today, the physician does tomorrow. So you can imagine everything that the patient will get depend on your wonderful diagnosis. So this is very important. And quickly to show you, that's the dome of Johns Hopkins, the famous historical dome, and that's the inside of the dome. And inside of the dome, there are these hallways which go on each side, lined by small rooms. They're still there, and these are the rooms where the residents used to live. So you can imagine all the hard work that these people used to do. And he said many wonderful things, something that we in Pakistan keep very dear to the heart when we decide to go to medical school and become physicians. He said, we are here to add what we can to life, not to get what we can from life. It's a noble profession. And we as pathologists adhere to the same approach, that we are serving humanity. We are playing such a vital role when we make diagnoses and play such an important role as a member of this multidisciplinary team. He said many other things, which especially apply to the trainees sitting here, that you clearly understand what's written here. Live neither in the past nor in the future, but let every day absorb all your interest, energy, and enthusiasm. The best preparation for tomorrow is to live today superbly well, to learn to enjoy what you do on a daily basis as a trainee and also as a practicing pathologist. And don't wait for something magical to happen tomorrow, some new molecular test, some new immunomarker. You have everything available to us today. And this is what Dr. Osler said, future is today. So make best use of what is available to you and enjoy what you do. I'm showing a quotation of Dr. Osler. Our own Maulana Rumi said something. We carry inside us the wonders we seek outside of us. So be confident. Never feel inferior to anyone. Be in competition with the best, because you can do anything you want. And this is the precious time in training, that you can make best use of the time. Again, I'm showing something to you that Rumi said, set your life on fire. Seek those who fan your flame. So be in competition with the best, your best colleagues from your own institution, other institution. Try to become the best with your training and hard work. And I will end with showing this quotation. Again, Rumi said, you're not a drop in the ocean. You are an entire ocean in a drop. Such a beautiful thing to say. So remember these quotations. With that, I end my unknown cases. I'm running a bit behind. I know Zubair might be online, but I'll just take a few minutes to introduce the International Academy of Cytology to you, something which I'm supposed to do, because after all, this is an IAC tutorial. IAC was established in 1957 in Brussels, Belgium, and these are the founding members. Dr. Zinser from Germany. This is Dr. Terzano from Argentina. This is Miss Graham, Ruth Graham, a cytotechnologist from the US. This is famous George Wheat, who's a gynecologist, also from the US, and Dr. Stoll from Germany. So this is the founding committee, the founders committee of the International Academy of Cytology. We have a leadership which is selected for 3 years. The leadership for 2022 to 25, 2022 because we just had the Baltimore Congress. So from Congress to Congress, every 3 years we have a leadership change. So the president now till 2025 is Fernando Schmidt from Portugal. I will take over as the president in 2025 at the Florence meeting in Italy. Past president is Andrew Field from Australia. The secretary treasurer is from Switzerland, Massimo Bongiovanni. And there are always 2 vice presidents. One of them would be a speaker here later this afternoon, Ashish Chandra, and Martha Pittman also from the US. So this is the board of directors. We have an executive board also. Kari Saryanan, who is also the editor for Acta Cytologica, Pam Mikolo from South Africa, Gary Say, who's the chair of the educational committee holding these tutorials, Donna Russell, who's a cytotech from the US, Yukitoshi Sato from Japan, and Esperanza Torres from Colombia. These are members of the executive board. We also have a board of examination called the International Board of Cytopathology, which was established in 1974, and the first exam was held in Chicago in 1978. To this date, some 600 people have taken the IAC exam from 50 different countries, and I urge those of you who are members, MIAC, to consider taking the fellowship exam. These are the original members. The first chair was Reagan, Patton, Johnston, Tom Bonfiglio from the US, Walker Schneider, the longest appointed chair a couple of years ago, retired, and I took over. So we worked very hard to update the exam, and now, as I mentioned to some of you, it will be a digital exam going forward. There is an IAC exam for the cytotechnologist. One is for the cytopathologist, and these are administered several times a year. The IAC membership has various types. The medical members, who are called MIAC, the largest group belong to the medical members. Then there are fellows, again, a large number. There are cytotechnologist members. So fellows are the members who, after 2 years of being member, take the board exam and become fellows. So they can write after the NMFIAC. And likewise, cytotechs also have an examination. There are non-medical members and there are junior members. And those of you who are in training certainly could consider becoming junior members. This is the breakup of, geographically speaking, since it's your European-based organization, most of the members come from Europe, but a large percentage are also from East Asia, from Australia and New Zealand. A large number are also from North America. And this is something that I leave it for you to think about. I'm just comparing membership between India and Pakistan. There is certainly a disparity. Very few members from Pakistan. So seriously consider becoming a member of the IAC. We'll have more presence here. And certainly, as being originally from Pakistan, I would love to see, especially the year I would take over the IAC presidency, that we have a good representation of pathologists and cytotechnologists from Pakistan in IAC. I know it's not easy to spend this money and become IAC members. The medical members, the admission fee is substantial, certainly yearly membership as well. But we do offer a junior membership and several other membership subtypes as well. And again, some requirements. I'm going to skip this slide. I already mentioned that you can certainly become an MIAC, a member of the IAC, by filling an application, having 2 fellows sign your application, attach your resume, a photograph, a very simple process which you could do online. And for fellowship, certainly you have to be a member for 2 years, then apply for membership, do an examination fee, and become a member. So Alison Austin, who is our executive manager, was very generous in making this slide for the participants of this tutorial. And she mentioned it to me that if you like to become a member at this meeting or till the end of July, the 140 euros membership fee will be waived. And the annual membership for this year will be reduced by 50%. So you only have to pay 95 euros today or till the end of July to become a member of the IAC. And certainly you can do the online application. It's available on the IAC website. And 2 people can co-sign your application. If you do online, you can certainly mention my name or Shahid, are you a fellow of the... Yeah. So some fellow can, if not, just write to me and I will have 2 fellows, including myself. Oh, Momin is here. Yeah, we can countersign your application. There are many benefits. Certainly, you can attend these tutorials, reduced fee. There is IAC Congress every 3 years. You will have journal access, Acta Cytologica, which is published 6 times a year, the oldest running pathology journal. We regularly arrange tutorials, just like the type we are arranging today. And we have webinars, we have YouTube presence, we are on Twitter, LinkedIn, so extensive social media presence. We hold companion meetings, not only at the European Congresses, but also at the US CAP meetings. And the next big meeting coming up is later this year, in end of September, beginning of October in Budapest in Hungary, the European Congress, where we will have a full day of IAC tutorial before the meeting, and there are other companion meetings within the European Congress. So I invite you to attend the next Congress, which will be in Florence, a beautiful city to visit. And at the end, I invite you to join the IAC and will personally welcome you if you decide to become IAC member. So with that, I end my morning session. It was wonderful to interact with you. I'll be coming back at the end of the day to do some unknown cases. Since we are running a bit behind and Zubair might be waiting for his presentation, I think we can limit any questions during the lunch break or for later. So once again, thank you so much for being a wonderful audience.